Hello, my name is Borsha. I work with Breakthrough, and I work with the media team there, work on advocacy, partnerships, and content, um, and also digital engagement. And thank you so much for joining this session 3. It's going to be a very, very interesting session because we're going to discuss very interesting innovations from healthcare to parenting, from decision making. In India and Nepal, we have 4 such presentations. So I really don't want to give a lot because I'm really excited and started reading about it. These are very, very interesting innovations. So we'll go like one by one. So the very first presenter, the topic is creating a scalable model for healthcare delivery and patient-centered care in rural India using telemedicine. A very, very interesting work. In increasing accessibility, in increasing affordability in terms of rural healthcare. The authors are Pallavi Jain, Anu Sachdev, Arvind Singhal, and Jagdeep Gambhir. So I'll request, Pallavi is here. So if you can come and present, thank you very much.
Wonderful. Thank you so much. Can I request the tech team to put up our presentation and share the screen with us?
Yes, ma'am. Give me 2 seconds. I share.
Oh, take your time, please.
Okay.
Yeah. Okay. Are we ready to begin? Okay, great. Good morning, everyone, and thank you so much for having us today at the oral presentation at SBCC in the Future Forward segment. We're looking forward to share our innovations with you as well as hear a lot from all of you. I'm Pallavi Jain, co-founder and director of the Change Designers, and today I'm joined by my colleague Anu Sachdev. Anu.
Hi everyone, I'm Anu, co-founder and director of the Change Designers, and unfortunately Dr. Arvind Singhal and Jagdeep Gambhir couldn't be with us today, but we'll take it forward, and if you have any questions, you can always get in touch with us. Thank you.
Thank you. Next slide, please. Okay. Back in 2016, when we started the Change Designers, we started as a communication organization that was designing for large-scale communication campaigns for social development. Next slide, please. As we began, we realized that it is not just design which is of utmost importance, but it is also communities and care that we give to them. That is something which does all the magic. And that is when you realize that communicating for outcomes that really, really matter, not just to us, but the people who we care for, who we design for, is very important. Next slide, please. That is a time around 2019 when we came across Karma Primary Healthcare, which is also known as e-doctor clinics. So Karma Primary Healthcare is a social business that provides primary healthcare in rural areas, essentially in Haryana and Rajasthan. Their purpose is to provide and make access easier to primary healthcare at affordable prices and providing quality. Next slide, please. So this is how typically an e-clinic, a Karma e-doctor clinic looks like in Haryana or Rajasthan. So it is mediated through a nurse and teleconsultations which happen with doctors. Karma has a network of doctors across urban India with different specialities, and they invite people from rural India to come to these clinics and take access of the systems that are being set up. However, despite setting up of such sophisticated models, such sophisticated technology, and also having trained nurses and highly qualified doctors, Karma was still facing the challenge of having increased footfall and generating that level of trust with people in the communities. That is a time when they call us in to understand that how is it that we can solve for this challenge and get more people to avail the services and the good quality healthcare that Karma is trying to provide. Next slide, please. Can we have the next slide, please?
Sorry, one.
Yeah. So that's a time when we realize that positive deviance can be one critical approach that we can apply in doing our inquiry. So positive deviance is essentially an asset-based approach, which looks at individuals and groups who practice uncommon behaviors and strategies for solving for challenges with better solutions that their peers are otherwise not able to do with access to same resources and the same challenges at hand. So then we started looking at different stakeholders that Karma engages with, right from patients to nurses to doctors and to outreach staff, and really trying to identify persons and most importantly, identifying what exactly are they doing to solve for the challenges that Karma is facing in increased outreach and increased patient footfall. Next slide, please. So keeping positive deviance at the forefront, we decided to create an entire intervention and identify practices at the same time, roll them back to our stakeholders so that they can be adopted for enhancement of the purpose that we were there for. So once we identified problem after carrying out a positive deviance inquiry, both in Haryana and Rajasthan, we tried to identify solutions within the community. We followed a process of design thinking, engaged with several stakeholders. Once we had those practices identified, we wanted to roll them back to the stakeholders. So following a learning by doing model, we try to zoom in and zoom out of the entire system and help the stakeholders and the network that was created by Karma to adapt these. Once we engaged people with these practices, made them familiar with it, we conducted about 12 sessions of trainings across 6 months and tried to make the stakeholders understand that it is not just the technology which is important, but also the connections that we make between humans, which is our patients, and our doctors. And that is just being mediated by technology. Next slide, Anu.
Fine stuff, huh? So what happens when you go to the doctor? The doctor touches you, feels you, takes your pulse, takes your blood pressure, and you really long for that physical touch of a doctor to tell you what's wrong with you and how can you fix it. But that's not the case. The doctor is not here. So the nurse has an added responsibility of making the patient feel as if they're being cared for. The patient is at the center of this technology. So here's this outlier nurse who does not focus so much on the technicalities of, what's the prescription going to look like or what's the diagnosis going to be like, but he really tries to build trust. And that's the first thing he does by saying, don't worry, tum theek ho jaoge. And that's the first level of assurance that this, onlooker of care has come to seek at an e-doctor's clinic. Another example, which is in the next slide, is of a nurse that does not just say, oh, we are going to do an e-consult and look, the doctor's going to come on a computer screen. She just uses the simple human analogy of how a doctor se mil pati hu. Instead of, unlike the other nurses who are trying to explain the entire process of technology-mediated healthcare to a layman, she just translated the technology into a human experience. Now, what do you do of such innovators, right? This is at the clinic. But outside the clinic are these outreach workers that go home to home telling people about the service. What are they doing differently? How are they driving more and more people to avail this service? Next slide, please. There's this outreach worker, Deepa, in Haryana, who tries to follow up with the patients right before their last dose is over. Instead of saying, oh, aapka follow-up miss ho gaya tha, she follows up with them just one dose before. And that's how does she do that, you might ask? She liaises with the nurse at the clinic, at the center that she's at. So these small little things that these people were doing in Karma itself allowed us to look intrinsically the innovations that exist. And then we were able to formulate ways of using these existing solutions, existing innovations, to then scale up to the entire staff and to scale up the entire business model. So over the next 6 months, through the experiential communication techniques that we utilized with human-centered design and SBCC, and going a little away from the traditional modes wherein we would say, here's the problem, I'm going to find a solution. We said, here's the solution, how do we take it forward? So in the 6 months through experience, there was a 4-fold increase in the footfall of patients at Karma Healthcare, just by keeping patients at center. Next slide, please. Next slide. This was one of the exercises we did for journey mapping. Communication dissemination through these 6 months became self-sustainable, and the communities became a part of eDoctor community. Few of the things that we did: Chai Baithaks, Friends of eDoctor, Sammelans. What that did, people started having a stake. It's like share market, but in rural India for healthcare. When people have a stake and have consciously made an effort to build something in their own community, their most likely outcome is going to be that they would make it stay. And Karma Healthcare proves to be a case in point for this human-mediated, technology-based solutions that we have that we think will otherwise themselves solve for problems. But here we have a case that wherein we can use SBCC with new methodologies such as HCD and design thinking and systems thinking to be brought together to what already exists and how do we scale it up. We had a lot of fun doing this, and I think a lot was learned, and we'd love to discuss that in Q&A section. But for now, I think we're at time, so glad to be talking about it today.
Thank you so much. Thank you so much. It was really interesting to actually listen to how this whole change in design can actually solve so many things, and also a lot of assumptions also. When we design something, it comes through a lot of assumptions, but in reality, things can be totally different, and we can seek such solutions. Thank you very much. It was a wonderful presentation, and thank you so much for being so much on time. We just finished on time. So I'll move to the next presenter. It's another very interesting presentation it's going to be. It's on machine learning and how machine learning can be used to enhance the quality, the MIL, basically monitoring and evaluation, and on a real-time check on the whole quality management. So the presentation is titled as Using Machine Learning to Improve Quality Assurance of Behavior Change Communication Program in Madhya Pradesh, India. And the authors are Neha Shah, Diwakar Mohan, Kerry Scott, and Amnesty Lebre. Who was the Neha? I can see Neha. So you're going to present?
Yes, I and Dr. Osama Umar will be presenting.
Okay. Hi.
Presentation.
Okay. So thank you. Over to you.
Thank you. Osama, do you want to pull up the slides?
Yes, definitely. Can you hear me?
My name is Neha Shah, and I am pleased to be here today with my colleague, Dr. Osama Umar, presenting on behalf of the Kilkari Impact Evaluation Team. Our presentation will be on the enhanced quality assurance processes we developed with support from the Bill and Melinda Gates Foundation for use alongside a cross-sectional household survey in Madhya Pradesh, India. We hope that it can be applied in the future to improve the quality of data collected using digital tools, whether this be as part of routine data capture apps used by healthcare workers, or in surveys, which is the example we'll be walking you through here. Before we jump into our quality assurance process, we wanted to provide an overview of what quality assurance entails. Per the World Health Organization, quality assurance is defined as any method or procedure for collecting, processing, or analyzing survey data that is aimed at maintaining or enhancing their reliability or validity. Factors that may impact quality can be categorized in two forms: intrinsic, which include those factors within the control of the researchers, such as the data collection tool and the implementation of the survey, and extrinsic factors, which include external factors that may impact data quality, such as the weather, interviewer-respondent dynamics, or the community environment. This quality assurance process study was a sub-study conducted as part of the N-Line household surveys for the Kilkari impact evaluation in 4 districts of Madhya Pradesh, India. For those interested in learning more about the parent impact evaluation or Kilkari program, scanning the QR codes on the slide will take you to additional reference materials. This sub-study sought to demonstrate the feasibility and acceptability of an SMS-based quality assurance system for improving household survey data collection. The objectives of the study were twofold. First, to identify the quality issues using back-end data analytics and machine learning, and second, to send notification of those errors to the field teams using automated short messaging services or SMS messages. To ensure the highest quality, we need to begin with the very beginning of data collection, tool development, and associated research questions. In our study, we had multiple checks on the language, user interface, and translation to ensure the tool was sound. In addition, we had multiple cognitive interviews with our population of interest to ensure that our questions were understood as they were intended to be in the original English version. As part of the tool development process, we additionally looked for ways to track enumerator engagement to enable the quality assurance process. This included embedding timestamps to the start and end of the tool as well as throughout individual modules. After the tool was finalized, we needed to examine if the implementation of the tool, both the people who were doing it and the process of it, were sound. This step included assessing the enumerators during training and ensuring they had the support they needed through both training and their direct supervisors. In-field coordination, the communication between enumerators, supervisors, coordinators, and analysts was key to ensuring there was logistic efficiency and a clear staff hierarchy. Once the survey was implemented, our quality assurance processes shifted to survey monitoring. These processes included multiple levels of in-field monitoring, including random spot checks and question review, and weekly data analytics of the survey data, which included both descriptive statistics of common identifiers and values, as well as a machine learning algorithm to identify rushed interviews.
Thank you, Neha. And now let's look into the SMS feedback system that we implemented. In analyzing the incoming survey data, we realized that some of the errors found in the surveys were consistently of the same nature and took a while to rectify due to the many levels of communication and time constraints on the field staff end. Thus, we implemented a SMS feedback system data flow framework to improve the timeliness of survey error notification through machine learning and error resolution. This system involved the data collection process continuing as they were, but when the data was uploaded weekly, the error algorithms would automatically run and generate SMS notifications that were sent directly to the field coordinators and supervisors, who could then speak to the enumerators directly and communication back to the survey coordinator and research associate to clarify the errors. After the implementation of the SMS feedback system, we assessed how the team viewed the SMS feedback system in 2 ways. The first was through qualitative interviews with the field team to determine how they perceived the existing data quality mechanisms, their experience with the SMS feedback system, timeliness of error notification, the modality of error notification, and the recipients of the error notification messages. The sample included 6 individual interviews and 1 focus group discussion. The second way included quantitative analysis to assess the time gap between interview date and error resolution. It was reported that SMS content for error notification was easily understood and had all necessary details to identify and resolve the errors. It enabled the supervisors and coordinators to contact enumerators individually instead of group meetings, and easy to resolve and thereby reduce their workload. Though the SMS was well accepted, the team indicated their preference for WhatsApp and also preferred group messages than individual ones. Regarding the message recipients, there was a mixed opinion as to whether everyone, including enumerators, should get messages. You could look into the screenshot of SMS error notification for duplicate ID and incorrect birth date to see how the SMS looks like for the recipients. In this slide, we summarize findings on the timeliness of error notifications. In the figure on the right, x-axis is the date of interview, while the left side, y-axis represents the weekly average gap in days between the interview date and when the error was resolved. What we see from the blue line is that the average gap in days declines overall and accelerates when the SMS feedback loop is introduced. When asked about the timeliness of error resolution, the team felt that the SMS notification system had made error resolution faster compared with the earlier in-person meetings. Respondents noted that with the earlier manual system, corrections were sometimes forgotten and not updated. In addition to the time required to resolve errors, we looked at the frequency of errors over time, which is also represented by the orange bars. Overall, despite some slight fluctuations over time, we can see that number of errors remained quite steady. It's possible that had the SMS feedback notification system been started early, we too might have seen further declines in the frequency of errors. So what are the final implications of this feedback system? The SMS feedback system helped the team resolve errors in a timely manner, thereby improving the data quality and reducing their workload as compared with manual notification of errors. However, the process of creating such a system is iterative and unique for each study or data capture application. For those thinking about developing similar systems, we encourage you to initiate them early in the data collection processes and embedded with the electronic tool system for tracking enumerator engagement, including timestamps and GPS location tracking. In the future, it could be applied to special surveys, household surveys, DHS, etc., and provided data capture applications as well. Thanks for listening to our presentation, and for those who are interested in learning more, please do see our publication in the BMJ Global Health that is part of a special supplement on digital innovations for community and primary health in India. For any further questions, please write to us using the emails provided. Thank you.
Thank you. Thank you for the wonderful presentation. We'll take all the questions when we finish all the presentations. So moving forward to the next presentation, it is okay. So this presentation is actually about how decision-making, this decentralization of decision-making and bottoms-up approach while strategizing any program can impact so effectively in changing the mode of, changing the access and changing the practice of healthcare. We have this wonderful presentation from Nepal. And the presentation is titled Helping Local Leaders Solve Local Problems Incorporating Evidence-Based SBC into Nepal's newly federalized system, including government, academia, and partner. The authors are Pranav Rajamani, Srijana Casey, Carol Jacobi, Sanjati Velu, Joe Henderson, Trishan Davis, and Treshan Koirala. I'll request the presenter to please switch on a camera. Okay, I see Pranav there. Hi, Pranav, over to you.
I have a pre-recorded session, so I request Hello everyone, my name is Pranav Rajamani. I work with the Breakthrough Action Project, John Hopkins Center for Communication Program, and I'll be talking about helping local leaders solve local problems using SPC. I'd like to start talking about the context. Nepal has recently moved to a federal system in the last 5 years. When the project started, it was only 2 years into this change. Now there are more than 750 local municipalities across Nepal that can independently make their own decisions about health. So there's a lot of potential for them to take the lead on this with using social behavior change communication. But there are also a lot of challenges because there is a need to build capacity and strengthen capacity for local leaders, implementers to use data to design, implement, as well as monitor evidence-based SBC programs. The SBC System Strengthening Project was implemented between 2018 and 2020, funded by USAID, with the objective of strengthening the institutional and technical capacity of the local government in Nepal to design, implement, and evaluate and coordinate effective social behavior change programs. We work closely with the National Health Education Information Communication Center, Family Welfare Division, as well as the provincial ministries of social development and the local municipality stakeholders. A learning by doing co-design approach was used as we work to strengthen local capacity. We work substantially, very closely with the local government staff, especially the health coordinators at the municipality level. Started off using self-assessments so that they would be able to themselves evaluate where they were at the moment. The tool used was SBC Progress tool that had been adapted for this use and contextualized in Nepal. So we both did a baseline for this, as well as at the end of the project we also used the same tool to evaluate the progress as well. And this baseline assessment helped us to get buy-in from the local authorities because they self-evaluated so that we could work closely with them to build their SPC capacity as we worked. And after the assessment, we also did a first off training with them. Then after the training, then we dived into co-creating and pilot testing the work as we moved along. We also worked with the system. So we did not try to create a parallel system. We were very sensitive in terms of ensuring that we were building into and strengthening the local government system. So we worked with the government annual planning process as the backbone of the process. And we also worked and discussed with the local municipality and other stakeholders about the roles and responsibilities that they would undertake to build this capacity. Following our visual snapshots of the process, as you can see, there was a lot of end-user consultations, discussions, reflections, mentoring, supportive supervision as we worked with the municipality authorities, the health coordinators. We also pilot tested the activities and also ensured that there was a lot of community engagement, talking to the community as we designed the learning and the project along with them. The approach was guided by human-centered design. We say guided because we did not follow exactly the phases, but in terms of consulting with the end users, working, co-creating with them in terms of discovering what works, generating ideas based on the discussions, and then coming up with a prototype that could probably work and testing it. We worked closely with them to do that. So the co-design thinking and the design thinking that we applied and can work with our local stakeholders led to this development of the social behavior change capacity strengthening support material at the local level. It's a skill-based job aid that was designed based on consultations, like deep consultations with the local level in terms of what their needs are, and with the pilot testing at the local level in terms of what is needed and what works. So what it does, it helps to use local data and helps them to pre-plan as they look at the programs. And also, once the programs have been endorsed, then they are able to implement that and use this book to also monitor for a social SBC. We've kept it very simple in terms of looking at, we've used the P process as the backbone for this. And so they're using it. It's based in Nepali as well as in English. The Ministry of Health and Population has also endorsed it, as well as the Ministry of Federal Affairs and General Administration, the National Association of Urban and Rural Municipalities. It was supposed to be rolled out a year ago, but due to COVID, things were delayed. But now the process is restarting in terms of training provinces and rolling out the trainings to all provinces so that this package can be used locally by various municipalities. As I mentioned before, this package is built around the annual planning process. And as you can see, there's a pre-planning phase, there's an advocacy phase, and there's an implementation phase. So the pre-planning phase is for pre-planning what can be proposed before the budgeting, the budget allocations, the discussions take place, so that the local municipality health section, social development section can sit and decide and can work on what works. So this all depends on looking at data, talking to the community, gathering information, and then themselves designing what is needed and how to present this in terms of the programs that are needed at the local level. And the local planning process involves consultations at the local level, to the grassroots level, and it moves up to the municipality level. So all that is integrated. So we've integrated SBC into that process as they do that. So once that is ready, then during the phase where they have to fight for resources and advocate for different programs. So again, the pre-planning process will help them bring that to the table and present the case so that they can advocate for needs and the way to present and what is needed at the local level, and how this planning process will help them allocate local funds, federal funds probably, take that forward. Once that is through and they've advocated that and they passed it and it gets endorsed, then the third phase, the implementation planning again kicks in, so that they can work on the post-approval of that in terms of planning the programs again based on probably some changes that have taken place, and then implementing the project, and as well as methods of monitoring what works. So all this is available online as well. You can see the website there as well. So what changed? So this N-line assessment that I'm presenting now is based on triangulation of three different methods. One is a most significant change evaluation with the self-capacity assessment that the municipality did themselves, as well as an outcome harvesting done by an external evaluator. So we understood that there's been an increase in understanding of SBC. They're incorporating the SBC activities in their annual 7-step planning process. They've allocated budgets for this. Now they're also focusing on the intended audience. They are listening to and reaching out to the audience when they plan the programs. And there's also involved in community level discussions, because now they understand the need to do that, to design programs. And evidence-based planning is also is improving. As well as the use of monitoring checklists at the local level. The elected bodies are also involved in the implementation in terms of asking for evidence, asking if the committee has been involved in the designing process, asked about it, right? And then the SBCC has been integrated into the local municipality health policy. So this is a quick visual snapshot of what I just talked about in my previous slide, talking about understanding of SBC, data use, community engagement, and policies, and the improvement in monitoring evaluation. Thank you very much for your time.
Thank you, Pranav. Do you want to add anything to this, or close it?
No, I think it's fine. I'll just wait for the questions.
Okay. Thank you so much. Those who are participating, please park your question because we are heading towards the last presentation, and then we'll take all the questions together. So the next presentation and the last presentation of the session is on how public sector and private sector can come together and change a lot of discourse about parenting and how that influence or impact children's healthcare. The presenters have worked in North India, and they have seen changes and how it worked for a larger healthcare system to change, bring change in the larger healthcare system, especially to do with children healthcare. So the presentation titled as Successful Parenting, a Public-Private Sector Partnership Saving Lives in North India. The authors are Pallavi Dhal, Surya A.V., Susan Mackey, Pradakshana Kaul, and Smita Singh and Abhishek Singh. I'll request the presenters to please switch on their camera.
Hi, Varsha.
Hi, Pallavi. Over to you.
All right. Hi, Abhishek is also here. So thanks for this opportunity. I think you have a presentation. This is definitely a very interesting piece of work that we have done in Uttar Pradesh. We have Archana and Abhishek as well. They are our implementing partners, and we were leading the research. And like you said, this is about impacting hand washing behaviors and immunization behaviors while concentrating on parenting as a platform. So I think I'll let you show the presentation, and we'll be happy to take any questions.
Can you please play the presentation?
Pneumonia and diarrhea are leading killers of children under the age of 5, claiming the lives of more young children globally than any other infectious disease. Despite progress in reducing diarrhea and pneumonia deaths in India, it still remains a major contributor of child mortality, harboring a fifth of their global burden. Unfortunately, the fact that these deaths are almost all preventable with vaccines and simple proven prevention methods such as hand washing with soap is underutilized. While India experiences some of the highest preventable childhood mortality of any country in the world, the most populous state of Uttar Pradesh has an infant mortality rate and under 5 mortality rate, strikingly high when compared to the national average. To respond to this complex situation, a new initiative, Project SAFAL Shuruat, was born to improve the health and well-being of 0 to 2-year-old children. Project SAFAL Shuruat, co-sponsored by Gavi, the Vaccine Alliance and Unilever Lifebuoy, is a 3-year-long unique public-private partnership. The project is implemented by Group M, which is the lead agency. The pilot, which began in June 2018 in 2 districts, Hardoi and Prayagraj, was completed in mid-2019. Post which, the scale-up in additional 2 + 12 districts have started in a staggered manner. When the project was envisaged, the challenge at hand was to integrate 2 disparate behaviors. Immunization and hand washing with soap are 2 behaviors which are quintessentially different. In terms of frequency, one is many times a day, while the other is 7 times in 5 years. One is care-seeking, while the other is caregiving. One requires visit to a health service delivery site, while the other can be practiced at home. The other critical challenge from a strategic communication perspective was to balance these behaviors equally, so that one did not get prioritized over the other in the mind of the audience. This challenge then led to the third big question, which was to bring these 2 behaviors under a common platform to positively impact early child health and development. The big question was that what possibly could be that common binding factor? These young parents, mother and father, think beyond self. Their worry for the health and future of their child helped us in placing these 2 preventive behaviors under the disease and infection control ambit. The vision of Project SAFAL Shuruat is to inspire and encourage young parents, both mother and father, to adopt these behaviors which will ensure the proper growth and development of the infant, such that the child is not merely surviving, but thriving, with the age-appropriate physical and cognitive skills. The project focuses on behaviors for the parents, of which immunization and washing hands with soap are integrated as protection from germs and infections, which is a gateway behavior essential to the child's development. It is a shift in the communication about these behaviors, as well as a reframing of communication on child health from survival to success. Every parent across different strata wants to do the best for their child, unless it is on account of knowledge, resource, or skill gap. Most parents are unable to figure out how to achieve their dreams for their children. They are unsure of the path to tread upon to realize their wishes, and most often than not, link it to their limited resources, which then converts into delaying any substantial action till the child actually starts going to school. Through this project, we are telling parents the importance of starting early, as the maximum brain development in a child happens in the first few years, during which the first and the foremost thing is to protect the child from infection and diseases, so as to avoid its negative impact on the age-appropriate development. And for doing so, immunization and hand washing with soap are two most cost-effective and fundamental behaviors to protect the child. In addition to this, providing adequate nutrition and nurturing the child with early enrichment activities goes a long way in making the child healthy and success-ready in life. Along with this, improved parenting skills forms a strong foundation for child on the path of success. This slide shows the 9 months of the pilot journey consisting of 4 program visits, Anganwadi Center, and school contact components, mobile reminders, and village-level launch and graduation events. A multi-channel media approach has been adopted to bring desired behavioral change, with special focus on IPC for interactivity, engagement, and fast learning. The household-level interaction, which is a critical part of this behavior change project, involves direct interpersonal communication with the primary target group and peripheral interactions with the influencers around. Each visit was planned to take the parent through a journey of learning and behavioral modeling through a mix of technology-enabled IPC sessions. So, once we had cracked the communication model, the next big consideration was how to take it to the audience in a way which would ensure an optimized implementation, fidelity, and rigor. So, then we came up with the concept of SAFALTA coach or the facilitator duos, the project feet on ground from the community, who would partner with these parents on this journey by not telling them what to do, rather hand-holding them effectively. Perhaps it's been for the first time that a team of male and female behavior change agents who are equally equipped and who share equal responsibility work as a team in these deep rural areas. The use of tablet enhanced the technology-led intervention through audio videos, interactive tools, and an integrated MIS for the back-end data-driven program management. The contact sessions were packaged with tools and assets like personalized calendar, environmental nudges, gamified and challenge tools, glow germ demonstration, mobile outbound calls, along with rewards and recognition to keep the parents engaged and motivated while ensuring optimized learning at the same time. Within 1.5 years of implementation, the government of Uttar Pradesh has been awarded for SAFAL Shuruat at the 6th National Summit on Good and Replicable Practices and Innovation in Public Healthcare Systems in India by Ministry of Health and Family Welfare, Government of India. Kantar had undertaken the research for the SAFAL Shuruat program, and we would go through the findings. The research was designed in a way that it provides a holistic evaluation to the program. The study has 3 different components: formative research, concurrent monitoring, and impact evaluation. Formative study was conducted in 5 districts of Uttar Pradesh and was aimed at understanding the current situation around overall health, diseases, as well as hand washing and immunization. This was largely a situational assessment. Concurrent monitoring was conducted in 2 districts of Uttar Pradesh and aimed at providing mid-course corrections and tracking the key indicators around hand washing with soap and immunization. We shall begin with the immunization findings in concurrent monitoring. The compliance data points were observed through the marked entries in the MCP card, which is seen as more reliable. The chart shows the age-relevant compliance to 3 key vaccines, Rota, Penta, and MR. The compliance of all 3 vaccines have seen an incremental rise. Constant reminders were an effective nudge to enhance knowledge. This can be seen from knowledge of vaccine-preventable disease and knowledge of 5 saal 7 baar, that is, taking the child 7 times in 5 years to get vaccinated. Both have increased significantly. 5 saal 7 baar had very high recall value among the participants and grew by 5 times from MV0 to MV5. Now we will talk about hand washing with soap findings in concurrent monitoring. Hand washing with soap is one of the trickiest behaviors to record, monitor, and track. This is such a personal behavior with high social desirability bias that capturing it needs great attention. We utilized a card sorting method to arrive at hand washing with soap behaviors. The chart shows knowledge and practice of hand washing with soap before and after certain identified critical occasions. Overall behavior change and knowledge rise has taken place in all the key occasions of hand washing with soap. The incidence of hand washing before or after each of these critical occasions saw a significant rise. The incidence of hand washing with soap post-defecation rose by 5 times over the 6 monitoring rounds. In order to assess the strength of the program exposure, cohort analysis allowed to look at the participants through the lens of degree of exposure. The graphs depict the respondent cohorts with varied levels of exposure to the number of program visits, vis-a-vis knowledge and practice indicators. The program reinforced the message of washing hands with soap every time before or after a critical occasion. With exposure to higher number of program visits, always hand washing with soap after defecation grew consistently. The knowledge on the criticality of washing hands in order to prevent diseases showed an incremental rise with exposure to higher number of program visits. The myopic association of hand washing with soap with visibly clean hands saw a shift over the monitoring visits. Similarly, for immunization, 5 saal 7 baar had a high recall value. The correct knowledge on the need for a child to be immunized 7 times in 5 years increased with increasing number of visits a participant is exposed to. Households with exposure to more number of program visits displayed greater age-relevant compliance of pentavalent and MR vaccines.
Thank you for the presentation. I'd request anybody from the team if you want to add anything to it, or then we'll directly go to the Q&A.
I think we're good to take any questions.
Okay, yeah. Okay. Great. So to the participants, please feel free ask questions. These are wonderful presentations, all of them actually, and very diverse also. Like in certain places, it's like accessibility, decentralization, targeting parenting in order to impact children's healthcare, machine learning. So it's very diverse and very interesting. So if you have any question, we have around 10 minutes, 12 minutes for the question answers. So any
Varsha, can I start? This is Priyanka.
Yeah, sure. Sure.
Hi, my name is Priyanka Dutt. I'm the country director for BBC Media Action. I don't think I need to introduce myself to lots of people on this call, so it's really good to see so many old friends. My question actually is to the one team that I don't know. So Pranav, this is for you. Fascinating work that you've been doing in Nepal with Breakthrough Action. I had 2 questions really, trying to understand how you were thinking about and what you saw with specific challenges in the work that you were doing. So the first one was just even in terms of getting buy-in at different levels to start the process of that human-centered design work. What kind of challenges did you face, and how did you kind of get around those? And my second question was, the processes that you talked about seem, completely logical and makes a lot of sense, because you want to get people thinking about, strategic data-driven SBC approaches. I wasn't completely sure how much of that focused on the need for sort of strategic content design. And it would be really good to hear you talk a little bit about that.
Thank you. Thank you for your questions. Let me start with the first question. In terms of buy-in, because in Nepal now we have three different levels of governance now: federal, province, and local. So in terms of
Pranav,
working with,
I'm struggling to hear you. I'm not sure if everybody else is as well.
There is some background noise.
You're muted at the moment.
Yeah. Hello. Can you hear me now?
Much better.
Okay. So the project itself, at the federal level, we had a buy-in right from the start, because when you come in working on the project, we work directly with the Ministry of Health, the Department of Health, NHEICC, which kind of works on the social behavior change component, as well as the program division in the health department, the family welfare division. So we had, in terms of orientation, working on what we were doing, so there was buying in there. But definitely there was also, as I mentioned, there was self-assessments that we did at different levels, at the federal level, at the province level with the ministries, and at the local level. So I think that was a key factor in getting buy-in. And I think it's a very critical part in that. I mentioned the progress tool, the SPC progress tool, which has both, if you know, it looks at the institutional capacity and the technical capacity of SPC. So we had used this before, prior to this project, but then we also refined that even further to look at what we were looking at, like in terms of domains, so looking at technical knowledge about SPC, knowledge about knowledge management, monitoring, evaluation, coordination, things like that. So in terms of buy-in, definitely, so the formal processes that we had working with the Nepal government at each level was part of that. But then the programmatic buy-in definitely was through the self-assessments, because once they are on board, right, then we just provide the tools to them. They discussed in their own groups about where they were at. There's a lot of discussions and debates, disagreements even within the team as they were looking at this. And they definitely were trying to say, I mean, they wanted to say they were doing really well, but then the progress tool, as you know, is you have to provide evidence in terms of how things are. So yeah, I mean, I think that was, then they had this aha moment in terms of, oh yeah, I mean, this is where we are. We need to really improve on this. And they designed the work plan in terms of, with us, in terms of where we want to go. In terms of the human-centered design, as I mentioned, it was not a totally focused. We didn't go through the phases, right, at that time. So it was basically, it was a mess, right? I mean, like with like designing a prototype, we were even not really sure where we were at certain points in time. But it was definitely a very co-design focused, working very closely with the stakeholders, because there were like two folds to this. One was definitely the material that we came up with was the end product, but the process itself was in terms of how do we build capacity at the local level. And the only thing we saw was that definitely training was needed, but then this mentoring, working very closely with them to get their attention. I mean, there have so many things going on. So how do you get them to pay attention to that? So we also had a local advisory group that we formed that kind of we work closely with them. So to get that level of buy-in. But I think that the key was the self-assessment they did before. So they could always go back and say, oh yeah, this is what we said we wanted to do, and the action plan. In terms of content design, so the core focus was definitely on the technical aspects of, I mean, because when we did the assessments, we found out that the evidence-based thinking was not there, right? It's very poor in terms of they just, year on, or they were just looking at what did we do last year? Okay, let's maybe add 10% and do that. And there was no consultation looking at data, like hard data, not looking at talking to the qualitative aspects of that. So that was a key focus. And and in terms of designing that, and we did do some part in terms of designing content, because
I mean, for us, because we were a system strengthening project and it was USAID funded, they did not want us to implement. So that was a hard thing. So in terms of designing content, we did do some work on that. And when we, in the Palika package, we call the Palika package, there's some content on that, but not a lot of because we had to keep it simple. There was we basically started from zero. So we had to do a lot of basic understanding on that. But the thing to focus on was that we asked them to look at the thing holistically, not just produce maybe one PAC or one voting board. I mean, they had to kind of think back in terms of how would that impact things. I hope I answered your question. Thank you.
Thank you very much.
Thank you so much. We have 1 minute left. If you have any question, please feel free to ask. Also, I want to let you know that we have also posted links, Zoom links in the chat bag for other sessions you want to participate. So feel free to join other sessions as well. They're excellent sessions planned today, tomorrow. So please feel free, join, engage and ask questions. Sadly, today we don't have time. We have to close the session. Thank you very much. Thank you all the participants for such amazing presentations. I'll be definitely thinking about it for some time now. So much insight, so much learning, and so much of diversity. Thank you very much. We'll close the session and please join the next session. The Zoom links are there in the chat box. Feel free.
Thank you,
everybody.
Thank you so much, ma'am. Thanks.
Thank you.
Thank you, ma'am.